Hey everyone, welcome back to the channel. I'm Professor Shaibu Oricha Bello, and today we're doing something I get asked about constantly. The pharmacotherapy of tuberculosis from the ground up. By the end of this video, you'll actually understand why we use the drugs we use, how the modern WHO regimens fit together, and the safety traps that catch people out. Whether you're a student cramming or a clinician brushing up, this is your one-stop guide. Grab a coffee and let's get into it. So here's the game plan. We're going to build this up in 6 clean chapters. Foundations first, then the first line drugs one by one, the standard and the newer short regimens, then drug resistance and mdr-tb, the new agents, and finally preventive treatment and special populations. Don't feel you have to memorize everything at once. Follow the flow, and by the end it'll click as one connected story. If you want to jump around, the chapters are in the description. Before any pharmacology, let's talk about why this matters. Because the numbers are staggering. Over 10 million people develop TB every single year, and it's still the top killer among infectious diseases, with around 1.25 million deaths annually. Here's the kicker: TB is preventable and curable. With the standard 6-month regimen, we cure about 85% of drug-susceptible cases. But roughly 400,000 people a year develop multi-drug or rifampicin-resistant TB. And that's exactly why getting the pharmacotherapy right isn't academic. It saves lives and it protects the whole community. Okay, foundational principle number 1, and if you remember nothing else, remember this: never ever treat active TB with a single drug. Why? Because in any big population of bacilli, resistant mutants already exist by chance, roughly 1 in a million for isoniazid, 1 in 100 million for rifampicin. Hit them with one drug and you just handpick the survivors, but resistance to both at once. 1 in 10 to the 14, rarer than the number of bugs present. That's the whole logic of combination therapy. And notice the 2 phases: an intensive phase to smash the actively dividing bacilli, then a continuation phase to sterilize the sneaky persisters. Let's lay out the whole toolbox. Up top you've got your first line heavy hitters: isoniazid, rifampicin, pyrazinamide, ethambutol, the classic HRZ. Add the rifamycin cousins, rifampicin and rifabutin, and that's the backbone of drug-susceptible TB. Then the second line and repurposed agents: fluoroquinolones, bedaquilinid, pretolaminid, lanzolid, clofazimine, and more. Don't panic at the list. We'll meet the important ones properly. For now, just picture 2 shelves: the reliable first line shelf and the specialist shelf we reach for when resistance shows up. Here's your first line cheat sheet on one slide. Screenshot this one. Isoniazid, a prodrug activated by catch, blocks mycolic acid synthesis, brilliant against dividing bugs. Rifampicin hits RNA polymerase, and it's our great sterilizer. Pyrazinamide works in acid, kills the intracellular persisters. Ethambutol hits the cell wall and mainly guards the others against resistance. And every one of them has a signature toxicity: hepatitis with H, R, and Z, and that classic optic neuritis with E. Keep this map in your head, the rest of the video basically colors it in. Let's zoom in on isoniazid, the cornerstone bactericidal. It's a prodrug switched on by the mycobacterial enzyme CATCHI, and then it blocks INA to shut down mycolic acid synthesis. That gives it the best early bactericidal activity of the lot. Two things to really lock in. One, it's metabolized by acetylation via NAT2, so you get fast and slow acetylators. Slow acetylators run higher levels and more neuropathy and hepatitis risk. Two, that's why we co-prescribe pyridoxine, vitamin B6 in at-risk patients to prevent the peripheral neuropathy. Cheap fix, big difference. The stereolipazine keystone. It blocks DNA-dependent RNA polymerase at the ApoB gene, and crucially it kills the semi-dormant persisters. Honestly, rifampicin is the reason we can cure TB in 6 months instead of 18. But here's the catch you must respect. It's a powerful CYP450 inducer. It will drop the levels of antiretrovirals, warfarin, the oral contraceptive pill, dozos, steroids. The list goes on. So when you're co-treating HIV, that's when rifabutin or dose adjustment comes in. Oh, and warn your patients. Orange tears, orange urine. Harmless but terrifying if nobody told them. Pyrazinamide, the intracellular sterilizer and a bit of a specialist. It's a prodrug converted to pyrazinoic acid by PINCE, and it only really works in acidic conditions. Exactly the environment inside macrophages and areas of inflammation. That's its superpower. It mops up bugs the other drugs struggle to reach, which is why it's essential in that 2-month intensive phase, and how we shortened continuation to 4 months. The trade-off, it's the most hepatotoxic first-line drug at higher doses, and it drives up uric acid, so watch for arthralgia and gout flares. Ethambutol, I call it the resistance guard. It blocks arabinosyl transferase and impairs cell wall synthesis, but it's only bacteriostatic at normal doses. So its main job isn't killing. It's protecting its companion drugs from resistance while they do the heavy lifting. The safety point, you cannot miss dose and duration related optic neuritis. It hits visual acuity and red-green color discrimination. And so counsel every patient to report any vision change immediately, and remember it's renally cleared. You adjust the dose in kidney impairment. Quick but useful, the rifamycin family compared. Rifampicin is your short half-life daily workhorse and a strong CYP inducer. Rifapentine has a long half-life, which is exactly why it powers weekly preventive therapy and those newer 4-month and BPLM era regimens. And rifabutin is the diplomat of the family, a weak inducer, so it plays much nicer with protease inhibitors and integrase inhibitors in HIV. Its own quirks are uveitis and neutropenia. Same family, 3 different jobs. Pick the right cousin for the right patient. Now, the regimen everyone should know called the standard 6-month course, written to HRZ/4HR. 2 months of all 4 drugs, then 4 months of isoniazid and rifampicin. About 85% success in drug-susceptible pulmonary TB. A few practical gems: daily dosing beats intermittent. Fixed dose combinations make adherence far easier, and you extend treatment in cavitary disease with a positive 2-month culture. And remember, CNS and bone TB need longer courses, often 9 to 12 months, plus steroids for TB meningitis and pericarditis. Here's where things get exciting. We can now go shorter. For adults and kids 12 and up with drug-susceptible pulmonary TB, there's a 4-month rifapentine-moxifloxacin regimen that proved non-inferior to the classic 6 months in the big study 31 trial. And for children with non-severe disease, there's a 4-month regimen to ZE, DINCH, RZ2HR. The catch on both, you have to select the right patient, no extensive disease, no known fluoroquinolone resistance. Used well, that's 2 whole months of treatment saved. Patients love that. Let's make dosing practical. Isoniazid 5 mg kg max 300, rifampicin 10 mg kg max 600, and take it on empty stomach. Pyrazinamide around 25 mg kg. Ethambutol about 50 mg kg, and adjust it in renal impairment while you monitor vision. In real life, you'll mostly use weight band, fixed dose combinations. Dose to the band and recheck when weight changes. Kids need higher milligrams per kilo because they clear these drugs faster. Don't just extrapolate adult doses to children. Time to talk resistance, and the vocabulary really matters here, so let's nail it. Mono or polyresistance is resistance to one or more first-line drugs, but not the H plus R combo. RTB is rifampicin-resistant TB, and we manage it like mdr-tb is the big one, resistance to at least isoniazid AND rifampicin. Our 2 best drugs gone. Add fluoroquinolone resistance and you're at per X DR. Add resistance to another group, a drug like bedaquiline or linezolid on top, and that's XDR by the Tulia 21 definition. Get these labels right because they completely change the regimen. Let's peek under the hood at the molecular mechanisms, because knowing the gene tells you how our rapid tests work. Isoniazid resistance. CAG loses the ability to activate the prodrug or INA alters the target. Rifampicin. Mutations in that 81 base pair hotspot of ERPOB, which is exactly what GeneXpert detects. Pyrazinamide is PINSA. Ethambutol is IMB. Fluoroquinolones are GRA and GRP. And for bedaquiline and clofazimine, watch that RV 6678 efflux pump. You don't have to memorize every letter. Just get the concept, one mutation, one mechanism, and that's why molecular testing is so powerful. When we build a longer regimen for DRTB, we group the drugs A, B, C, and it's genuinely simple. Group H, use all 3 if you can. Fluoroquinolone like lofloxacin or moxifloxacin plus bedaquiline plus linezolid. These are the core. Group B, add clofazimine and cycloserine to strengthen it. Group C is the reserve bench, ethambutol, delaminate, pyrazinamide, carbapenems, amikacin, and others. You bring these into reach to reach the required number of effective drugs. Think of it as building a team start with your stars, then fill the roster. This is the game changer, the 6-month all-oral BPL, pregabalin, pretomanid, linezolid. It's for mdr-tb and pre-AXDR in adults and adolescents 14, any HIV status. If fluoroquinolone resistance is confirmed, you drop the moxifloxacin and it becomes B-pile. And the evidence is stunning. In the TB-PRACE-AL trial, BPM hit around 89% success versus about 52% with the old standard of care. 6 months, all oral, no injectables, that is a revolution in mdr-tb care. Just remember not in pregnancy and watch the QT and those linezolid side effects. But BPM isn't for everyone. So what are your other options? If a patient doesn't meet the criteria, there's a 9 to 11 month all oral bedaquiline containing regimen for mdr-tb without extensive disease or fluoroquinolone resistance, and for the complex cases, extensive resistance, severe disease, or CNS and bone involvement where BPM is excluded, you build an individualized longer regimen of 18 to 20 months from groups A and B with at least 4 effective drugs. The cross-cutting rule never changes. Get drug susceptibility testing and design around it. Let's give the newer and second-line agents their moment. Bedaquiline blocks ATP synthesis and has a very long half-life. Watch the QT and the liver. Pretuminid and delaminid are nitroimidazoles hitting mycolic acid synthesis. Again, mind the QT and hepatotoxicity with pretuminid. Linezolid is a fantastic drug but demands respect. Myelosuppression and peripheral and optic neuropathy on long courses. Clofazimine causes that characteristic skin discoloration. The theme across this shelf: powerful drugs, real toxicities, which is why active safety monitoring matters so much. Switching gears to prevention, because stopping TB before it starts is a huge win. This is TB preventive treatment, and the modern favorites are the short ones. 3-HP is weekly isoniazid plus rifampicin for just 12 doses over 3 months. 3-HR is daily isoniazid and rifampicin for 3 months. Great in children. There's also 1-HP, the old 6-H and 9-HA, and 4-R for isoniazid sparing. But the golden rule before AN of these: rule out active TB first. Preventive therapy is basically monotherapy. Give it to someone with active disease and you'll breed resistance. Exclude active TB every time. TB and HIV, one of the most important combinations in medicine. Rule 1. Start antiretroviral therapy in everyone with TB, EHEB, whatever the CD4 count. If CD4 is very low, under 50, start ART within about 2 weeks of TB treatment, otherwise within 8. The exception is TB meningitis, where we're more cautious because of IRIS. Then the interaction headache. Rifampicin induces the metabolism of many antiretrovirals. With dolutegravir, you keep it but double the dose to 12 hourly. With protease inhibitors, swap rifampicin for rifabutin. Now these 2 moves and you're most of the way there. Pregnancy and breastfeeding, and the reassuring headline is treat TB, don't delay. The first-line drugs HR, E and Z are considered acceptable in pregnancy by WHO. So the standard regimen can be used. Untreated TB is far more dangerous to mother and baby. And give pyridoxine with isoniazid throughout. What to avoid? The injectable aminoglycosides, streptomycin and amikacin, because of fetal ototoxicity, and classic bipylamidine because pretuminid lacks pregnancy safety data. For DR-TB in pregnancy, fluoroquinolones, bedaquiline and demanid are used when the benefit outweighs the risk. Organ impairment, let's keep it clean. In liver disease, rank the culprits. Pyrazinamide is the worst. Then isoniazid and rifampicin roughly together. Ethambutol and the fluoroquinolones are essentially non-hepatotoxic, so they're your friends here. Mild, stable disease, usual regimen with close ELF-FT monitoring. Advanced disease, to drop the worst offenders and lean on the safer combinations under specialist care. In renal impairment, it flips. Isoniazid and rifampicin are handled by the liver, so they're relatively safe, but pyrazinamide and ethambutol need dose or interval adjustment because they're renally cleared. Match the drug to the failing organ. TB in children, and the good news is they generally tolerate these drugs really well. Same first line agents. Non-severe disease gets that 4-month 2-HRE/2-HR regimen, while severe disease and TB meningitis need longer courses plus adjunctive steroids. Dosing is where people slip. Kids need higher milligrams per kilo because they clear the drugs faster, so use the pediatric water dispersible fixed dose combinations, dose by weight band, and recalculate as the child grows, and give pyridoxine to HIV positive, malnourished, or breast infants on isoniazid. Let's put all the toxicities on one map. This is your safety dashboard. Hepatotoxicity, pyrazinamide, isoniazid, rifampicin. Peripheral neuropathy, isoniazid linezolid, cycloserine. Optic neuritis, ethambutol and linezolid. QT prolongation, bedaquiline, delaminid, moxifloxacin, clofazimine. Myelosuppression, linezolid. Photo and nephrotoxicity, deaminoglycosides. So your baseline workup writes itself. Liver function tests for everyone, vision checks with ethambutol and linezolid, and ECG when you're using QT, prolonging drugs, and blood counts on linezolid. Baseline it, then monitor it. Let's go deeper on drug-induced liver injury, because this is where you protect your patient. Risk factors: older age, regular alcohol, pre-existing liver disease, hepatitis B or C, slow estilator status, malnutrition, HIV, and other hepatotoxic drugs stacked on top. Now memorize the stop rules. They get examined and they matter clinically. Stop all hepatotoxic drugs if ALT is 3 times the upper limit with symptoms, or 5 times the upper limit even without symptoms, or if there's jaundice. Then you withhold H, R, and Z, exclude other causes, let things recover, and carefully reintroduce. Know these thresholds cold. Adherence? Honestly, the best regimen in the world fails if the patient can't finish it. So support it. Directly observed or video observed therapy for those who need it. Fixed dose combinations to cut the pill burden, and real patient education plus social and nutritional support. Then track your response. Sputum smear and culture conversion, especially at month 2. Monthly weights to keep dosing right, and toxicity surveillance with LFT-IS, vision ECG, and blood counts. For mdr-tb and new drugs, that's active drug safety monitoring. Treatment is a partnership, not a prescription. Alright, let's lock it all in with the 10 things to remember. Never treat TB with a single drug. Now your ripe roles. Rifampicin and pyrazinamide sterilize. Ethambutol guards against resistance. Standard drug susceptible TB is 2-HRZE/4-HR, and a 4-month regimen can shorten it. Know the signature toxicities: hepatitis with H, R and Z, neuropathy with H, optic neuritis with E added pyridoxine with isoniazid. MDR means H plus R resistance, and BPALAM has transformed mdr-tb care. If these 10 stick, you genuinely understand TB pharmacotherapy. And that's a wrap. Everything we covered is built on the WHO Consolidated Guidelines. Module 4 for treatment, Module 1 for prevention, Module 5 for children, plus the operational handbooks and the ATS, CDC and IDSA guidance, all linked in the description. One last thing, always cross-check dosing with your national TB program, because local availability and rules vary. If this helped you, hit like, subscribe and drop your questions in the comments. I read them. Thanks so much for watching, and I'll see you in the next one.